3, 2, 1. Good evening again, our dear friends and viewers, Cardiology Education Channel members from all over the world. Tonight is a very exciting night. We are finishing the year 2020 with all the events, scientific and unscientific, that happened during this year. So we have lots of scientific updates during the year 2020, and we'll be dedicating the month of December for all the sessions to be discussing those most recent trials and scientific updates. So actually we have tonight, I'm so excited to have Dr. Fadi Girkis, President of the International Young Academy of Cardiology, EAC, and cardiology consultant in United Arab Emirates. Dr. Fadi will be discussing with us two important clinical trials, the Dapa-CKD, dapagliflozin in chronic kidney disease, and the Affirm acute heart failure, ferric carboxymaltose for iron deficiency anemia patients with acute heart failure. So Dr. Fadi will start his discussion, and this will be followed by Dr. Ahmed Bindari, lecturer of cardiology at Banha University. I will introduce him and introduce his lecture also in the second half. So please, Dr. Fadi, you have the mic. You can start, please.
I think I was muted.
Yes,
I'm okay.
that's fine. You are ready now.
Okay, wonderful. Thank you. Thank you. Thank you very much, dear Karim, Zahran, and all the co-founders of the extraordinary group of the Cardiology Education Channel. I'm really quite privileged for inviting me on your successful scientific tutorial sessions. So allow me to sum up the two trials I will talk about this night. I will try to be straight to the point. So I will speak about two of the main recent breaking trials this year, which I think very soon the guidelines will address its inclusion as a class 1 recommendations and its proper indications according to the subset of patients. Before I round to the study design, objectives, and results, I will try to highlight some basics here at the rationale of the trial of the Dapa-CKD trial. We know that there is a very close link between the heart failure and the CKD. And it is well established through the previous studies and the practice. Previously, there were only ACE and ARBs as proven medications to slow the progression of the CKD. However, the Dapa-HF last year and then the Dapa-CKD this year have changed a lot concepts. And it changed a lot when it comes basically to improving the cardiovascular and renal outcomes, independently of the presence or absence of diabetes. Ultimately, around 700 million people around the globe suffer from the CKD today, and it's been rising on the list of permanent causes of death. And as of all, you know that because it's asymptomatic in early stages specifically, in average, there is around from 80 to 90% of people with CKD are undiagnosed. And you can see here in the first slide on the panel on the left that from 1990 to 2017, there was a rise in the CKD rank from 17 to 12 at the most common cause of global mortality, which is a kind of big change for sure. Working with diabetes, you probably know that diabetes is the leading cause of chronic kidney disease, especially uncontrolled ones and long-term diabetes. And another major contributor as well, as you all know, is hypertension. So part of this is the concern of what to do with the CKD. You can see in this slide that it shows successful trials during the past 20 to 30 years. And on the top, there is diabetic kidney disease over here. And there is a non-diabetic kidney disease. So basically, there was a lot of trials on both the ACE inhibitors, as here in the lisinopril and captopril trial, and even later on the ARBs. Since then, they became the standard of care in diabetic and even non-diabetic CKD. And then Credence came in 2019, which there was the medication of canagliflozin. It was the first study, in fact, to focus on patients at risk of kidney outcomes and promote those outcomes to the primary endpoint. So you all know that it was stopped early due to the efficacy on both protecting the heart and the kidneys as well. And after credence in 2019, SGLT2 inhibitors were firmly entrenched as the standard of care. Going from prevention to treatment, this slide is very important because you can see that there are the two twin trials, the Dapa-HF and the Dapa-CKD. And it explored the benefit of the SGLT2 inhibitors in both studies, from the prevention to the treatment, like I said. So the Dapa-HF on the left side, it tested basically the HFrEF patients with and without diabetes for primary cardiac endpoints as worsening heart failure or cardiovascular death. However, the Dapa-CKD, on the other hand, tested the CKD patients, the chronic kidney disease patients, basically, also with and without diabetes, but mainly for the primary renal endpoints, not only the cardiovascular endpoints. This slide is here to show how close is the association between the kidney function and the heart failure. To the left, this one, where it depicts very well that patients with chronic kidney disease, which is the blue lines, have almost double the incidence of heart failure, either HFrEF or HFpEF, which is the blue line, compared to the patients without the CKD, which is the red line. So, so basically, these are the patients with no CKD and heart failure, and these are the patients with chronic kidney disease and heart failure. And there is a way big difference in the incidence rates of heart failure, which is higher in those with the CKD compared to those without. On the right panel here, it showed that if you have heart failure, which is the dark blue color, then you have much more incidence of progression to CKD than if you do not have heart failure, which is the light blue color. So you can see here that even the mortality increases significantly if you have heart failure than if you don't have the heart failure. Dapa-CKD objectives and design. So it was basically to assess whether the treatment with dapagliflozin compared with a placebo reduced the risk of renal and cardiovascular events in people with chronic kidney disease, whatever they had or they didn't have diabetes at that time of the study. In fact, this study was ended prematurely due to the obvious benefits regarding marked reduction of both renal and cardiovascular events in patients during the study. You can see over here that the study lasted for around 2.5 years. With a one-to-one randomization. So almost 4,300 patients in a multi-center study for patients with and without diabetes. This is basically the more of the inclusion, the criteria and the study protocol. The Dapa-CKD enrolled patients with proteinuria, and this is very important. You can see here that these are the patients older than 18 years old with proteinuria and kidney impairment. But they excluded actually the patients with non-proteinuric chronic kidney disease, like, for example, the polycystic kidney disease. This is basically a CKD, but without a proteinuria. So they were excluded from the trial. Also, the NIHA class 4 heart failure patients were excluded at the time of the study. So this is very important. The primary outcome or the endpoints of the study, it was basically more than 50% decline in the estimated GFR, along with the occurrence of the end-stage kidney disease and death from a cardiovascular or a renal cause, or both together. So you can clearly tell here very much that baseline data were almost the same in both groups, receiving DAPA versus placebo, regarding the age, the sex, the type 2 diabetes presence, any cardiovascular disease like MI, atrial flutter fibrillation. They were just the same regarding the numbers as per placebo as well. So kindly bear with me here to understand the results according to the primary and the secondary outcome. This is the most important slide, in fact. As we spoke, these are the primary endpoints in the previous slides, and the secondary endpoints included were mainly related to the cardiovascular deaths or heart failure hospitalization and all-cause mortality as well. Look at how significant are the p-values over here, and the surprisingly reduction of both the primary and secondary outcomes. So the decline of the events as occurrence of end-stage renal disease and cardiovascular and renal death, along with the heart failure hospitalization, is just very amazing. You can just look at the p-values and you can tell this is the placebo and this is the DAPA. the p-values are very significant in all the primary and the secondary outcomes compared to placebo as well. You can also depict here the extreme benefit of both groups, of both patients who have baseline cardiovascular disease and who don't have cardiovascular disease as a baseline. So the dotted lines are the patients who doesn't have cardiovascular disease. And the straight lines, like here and here, they are basically the patients who has baseline cardiovascular disease before enrollment to the study. So you can tell from this slide that both groups showed significant benefit in terms of primary and secondary endpoints when receiving DAPA versus placebo. So it translates to the fact that dapagliflozin in chronic kidney disease patients shall be given to those with and without cardiovascular disease. So regarding the summary and conclusions, I'll just start with a hint on the Dapa-HF trial in 2019 and the Emperor-HF trial in 2020. They drew our attention actually to the benefits of SGLT2 inhibitors in halting the heart failure progression and lowering the cardiovascular mortality in patients with diabetes as well as patients without diabetes. So to conclude the study results, the results of the Dapa-CKD are consistent with those results of the Dapa-HF as well. And it was even concluded that DAPA delayed the initiation of dialysis in addition to reducing the number of deaths due to the kidney diseases. And it should be noted as well that both in Credence trial and here in Dapa-CKD, the drugs were continued all the way down to dialysis. And hence this practice definitely has support. There is no need to stop at a GFR threshold once they are started, once the DAPA is started. You can continue till the line of dialysis even. And regardless of the presence or absence of diabetes, DAPA significantly lowered the renal and cardiovascular events and death when compared to placebo. So Dapa-CKD, to sum up, is the first SGLT2 inhibitor trial to declare a favorable clinical outcome in non-diabetic CKD patients. Let us hope that the advent of the SGLT2 inhibitor bestows a new era in the field of nephrology. And this is very important, by the way. I will stop here before going to the next trial, which is the Affirm acute heart failure trial. Dear Zarhan, in case there is any comments from the respected audience or any queries.
Thanks a lot, Fadi, for this great overview of the Dapa-CKD. Karim, do you have any questions or discussions for Dr. Fadi before we move to the next trial?
Yes, thank you so much, Fadi, for this elegant demonstration of the Dapa-CKD trial. As a cardiologist, I believe we are now convinced that SGLT2 inhibitors are very beneficial in preventing the progression of cardiovascular disease, heart failure, and kidney disease. And these drugs are very efficient now in management of all cardiovascular and the renal disease as well. So, Fadi, I'd like to ask you some salient features of Dapa-CKD trial. I believe we have a median GFR in this trial of 43 milliliter per minute. Is it right?
Yes, exactly. That's true. So basically, it didn't include the patient.
Yes. So,
yes,
what about? So, do you hear me well, Fadi?
Yes, Karim, I was just highlighting this slide regarding to your nice comment that you can see here, according to the protocol, it was included according to the creatinine clearance, the 25 to 75 mil per minute per 1.73 meters square, and as well as proteinuria. That
Yes.
was part of the inclusion criteria. They didn't exceed the 75 and they didn't go lower than the 25.
Yes. So we have a median GFR in this trial of 43. I also read that the GFR less than 30 was in about 14% of the analysis. The efficiency of these
Kareem, I think I'm losing you.
in the different.
Voice is interrupting. Sorry,
Yes,
can you just?
can you hear me now, Fadi?
Yes,
Yeah,
Karim,
now
please,
much better.
can you
So,
repeat your question, please, Karim? Okay, so I think until Karim is back, um, so we have a question actually on online. Is there a difference between credence and Dapa-CKD as trials discussing the same issue, Fadi?
Yeah, basically the credence didn't really
I'm
rely.
asking.
Yes, Karim, please, can you?
So,
Yes, your connection is a little bit
can
glitchy.
you hear me now? Sorry.
Yes, we can hear
Yes.
you. Okay, okay. You can continue with your question, and then we'll take the question from online. So please mention your question, Karim.
Can you hear me now, Zaran? Yes.
Yes, yes, yes.
About, in 14% of patients, which is a considerable proportion of patients in this trial. So, if this drug is effective more in with the low GFR, high GFR, or we don't have analysis regarding this point.
Yes, I'm listening to you, Kareem.
The question Karim is mentioning is that is this drug more effective in the low GFR than the high GFR, or all the population of the patients included according to the GFR showed the same benefit from the medication?
Yes.
Well, yeah, because there was a wide range included in this study, which is, I think, is in favor and it's a virtue because it started, like I said, from a 25 to 75 as a creatinine clearance. So it included a wide range of patients, and even patients without cardiovascular disease as well, not only patients who has cardiovascular disease. So I believe that this study is even more important than credence. This included a wider range of GFR. In addition, that in both actually credence and Dapa-CKD, they just went along the line till the dialysis. I mean, during the study, the patients, just in opposition to the placebo, they were continuing in the study, even there was like already a starting lower GFR and any issues with the kidney till the dialysis, till the point of the dialysis. And the DAPA was not stopped for those patients in both and DAPA. So I think, like I said, there is a big support in this study, which is like there is a nice message at the end that you don't need really to stop at a specific GFR threshold once you started with DAPA. Because apparently these medications, specifically the DAPA and the empagliflozin, are kidneys, kidney friendly. So there is no harm that you can continue with these medications for the patients even.
Dr. Fahad.
So this is very nice and very promising, actually, Fadi, that you have this benefit in the wide spectrum of patients, even if the GFR is actually low or very low, the benefit is still continuous for those patients, and maybe this is also the same benefit that we got from the same class of medication in patients without heart failure. You still got the outcomes were positive from the cardiovascular point of view. And here you're getting the outcomes is positive, even in the extreme range of renal disease, which is actually very, very, very promising and represents a real light of hope for those cardiac and those renal patients. I have a raised hand actually from the questions. Would you like to mention your question, or would you like to post it? Okay, so that's nice. Kareem, your connection is a little bit glitchy. I cannot catch your voice. Maybe you can find a proper space a little bit for the connection. So we have a question from Dr. Kamal Zia. Uh,
I yes,
Yeah,
yes,
yeah,
yes.
thanks. Hi, Doctor, for the nice presentation. Just
Kamal, thank
wondering just wondering, we can start using DAPA in mild to moderate renal insufficiency. Is there any further role of ACE inhibitor in combination or with DAPA or in these studies?
Yeah, well, the actually the Dapa-CKD, they didn't really like excluded the ACE or the ARBs in those patients. But the thing that, like I showed in the previous study, the only medications which were available in the market and for the clinician to support the kidney in those kind of patients were only the ACE inhibitors or the ARBs. Like I'll show you the same slide that I'm talking about, which is this study. See, since 30 years now, there's been a lot of studies and trials, which were, by the way, very successful. And but you can see that those trials were done basically both on the diabetic kidney disease and the non-diabetic kidney disease as well. And most of them were successful, but they're included more the ACE inhibitor and the ARBs. And still the patients are having more deterioration for the kidney function. And there was no much significant results, like I showed you in the p-values and the significant reduction of cardiovascular death and mortality with the DAPA. If you compare with the old studies, like the renal, the Benedict, and roadmap, and all those studies, even with the credence. So that adds up to to our clinical practice that this is we can call it like a medicine for both the cardiovascular, to reduce the cardiovascular risk factors for both non-diabetic and diabetic patients, and to improve the renal outcomes and halt the progress of the kidney disease. So yeah, this is what I can shape it for
Okay,
you.
so this is the future now. We'll be using DAPA alone instead of ACE inhibitors, right? Oh.
Um, Fadi, hi, it's Hani Sabor. How are you?
Hi, Hani, how are you? How you doing?
Great talk, man. Thank you. As usual, I think it's just important to highlight that in these studies, one of the enrollment criteria that you have to be on a stable dose of an ACE or an ARB prior to enrollment, right? So it's on in addition to standard of care. So the main idea is that this is a new study where you looked at diabetics and non-diabetics, and not only did the renal outcome improve after an initial dip, but you actually got a cardiovascular death benefit, which is kind of remarkable, right? I mean, we've never seen studies where you actually get into the study because of one indication and you get out of the study with another two. So this is really, I think, where we all have to really be very clear on the SGLT2 inhibitors. They're basically drugs for a lot of things: heart failure, diabetes, ASCVD. And the more of us know, like you have informed us very nicely, of the indications and the requirement, this is basically like more powerful than a statin, and keeps the kidneys in check as well. So I think this is really very nice of you to present and summarize the study in this very nice way.
Thank you, Henny. Thank you. You just posted a very important comment, and I think it's very crucial here because, like you said, it's a very important medicine now, and it's not just for the cardiac medication or to reduce the cardiovascular risk. But like you said, now we can even use it in the chronic kidney disease patient. And like you said, this slide, like I show you here, the outcomes were amazing even with the patients who doesn't have a baseline cardiovascular diseases. So that translates to the fact that DAPA in CKD patient, only CKD patients, without cardiovascular disease, they shall be given to those patients as well. So I completely agree with you.
Eddie, I have a very nice and interesting comment from Dr. Paula Shohdi. He's a lecturer of cardiology at Suez Canal, and he's one great colleague. Actually, I love these discussions very much. He's asking you about the DAPA heart failure and the usage of dapagliflozin in patients to reduce the cardiovascular outcomes, even if they do not have heart failure. So he's asking how frequently do we do that? Do we actually use it in non-heart failure patients to improve the hard cardiovascular endpoints? So I answered him personally, I do. I do add it actually to sacubitril, valsartan, neprilysin. I do it a lot actually, and I do get very positive results. But I don't know if this is off-label or this is. Do you usually use dapagliflozin for non-heart failure patients?
Yes, the thing that, see, if you're talking about the non-heart failure patients, I think we should also put some kind of divisions. Like we have to talk about three kind of patients: the HFrEF and the HFpEF, and the patient without heart failure. But the thing that there is another subset which was included in the criteria of this study, which is the patients who doesn't have cardiovascular disease as well. The study that you can see right now in front of you, it proves what you said, Zohran, that we should use it in patients even with just CKD, and it will improve very much the outcome of the chronic kidney disease, apart from the patient if he has or if he doesn't have a baseline HFrEF or HFpEF even. So in fact, I've been using it for most of my patients without heart failure in the past period, but for some subsets of patients, and that was included in the post hoc analysis or the sub-analysis of the like morbidly obese patients, patients with AFib but controlled, patients with hypertension and comorbid illnesses. So the point here is whether to use it for those patients with diabetes or without. In the study, in the inclusion criteria, you can see here that in fact, they included a lot of subsets of patients, even the patient without cardiovascular diseases. And they ruled out some patients as well, the patients like with recent ACS and all those acute heart failure patients and all that. So the thing that I believe that maybe in the next few months or maybe in the next couple of years, there's going to be an addition on the guideline that this data should be used in most of our patients that we encounter, and they shouldn't be like a must that they have a heart failure, whatever it was, HFpEF or HFrEF, but they might be having the cardiovascular disease entity itself, like coronary heart disease, for example, without the heart failure. But this was not really proven 100% here. We cannot talk about it right now. This is only like that subset of patients without the cardiovascular disease, like you see here. There was extreme benefit from both groups if you give DAPA to patients without cardiovascular disease. So that's why they translate the fact that you should give these patients, even without cardiovascular disease, dapagliflozin. But if they have chronic kidney disease, but if they don't have chronic kidney disease, I think there should be a lot of questions and later on discussions and more trials to prove that point that Dr. Paula and you also just posted right now.
Thanks a lot, Fadi, for this great discussion and for all the panelists also. So maybe it's time to move to the next clinical trial. So Fadi, please start sharing your slide.
Thank you very much. Thank you. So I'll be quick because I think I'm pretty late and I should be having only 15 minutes maximum. So the next and the last trial, which is Affirm acute heart failure trial. And it's a randomized double-blind placebo-controlled trial comparing basically the effect of intravenous ferric carboxymaltose on hospitalizations and mortality in iron-deficient subjects and those who are admitted for acute heart failure. So you all know that it was presented lately on the 13th of November of this year in the American Heart Association Congress. See, the incidence of the iron deficiency, it has been suggested that the iron deficiency could be present in up to 80% of the patient hospitalized for acute heart failure. And the iron deficiency per se, even without the presence of heart failure, it was a very poor predictor of outcomes, regardless of the previous history of heart failure, regardless of previous history of high BMPs or even the baseline ejection fraction. So even in patients with normal heart and those with heart failure with preserved ejection fraction or HFpEF patients, there's been poor outcomes when it comes to the iron deficiency. And this ultimately suggests that depleted iron stores might have a strong, unfavorable impact on the natural history of this clinical syndrome beyond the cardiovascular status. So the study design in brief, it was randomized as 1-to-1 placebo trial, double-blinded. So they used to give the patients ferric carboxymaltose, and the placebo, they used to receive normal saline and basically in black syringes because it's a double-blinded, like you know. So subjects received between 500 and 2,000 milligrams of ferric carboxymaltose. So it was basically based on the weight and the hemoglobin level of the patient. Total number of the enrollees was 1,132 patients, 52 weeks of follow-up. The age of the patient, the mean age was around 71 years. So bear that in mind. This study was basically made for the elderly patient. And this is very important. I'll tell you later in the next slides why. And there was 41% of the enrollees were diabetic. So inclusion criteria for the Affirm acute heart failure trial, elevated BNP or NT-proBNP, in addition to admission with acute heart failure, low serum ferritin, less than 100 nanogram per ml, or if ferritin levels are normal, then the transferrin saturation should be less than 20%. And later on, I'll tell you how to calculate it practically and clinically. It's very easy. So the ejection fraction in the enrolled patients should be less than 50%. So basically, the patients were in the criteria of the HFrEF patients, not HFpEF. Patients with severe anemia, like less than 8 milligram per deciliter, or above normal hemoglobin level more than 15 gram, they were ruled out from the study, as well as acute coronary syndrome or recent CVA patients. They were excluded from the study. So this is the main endpoint, which is the total heart failure hospitalization. This is a primary main endpoint. So you can see here, the red are the patients who receive the ferric carboxymaltose. And the gray line is the placebo arm, which received the normal saline in a black syringes. So you can tell here that there was around 48% at least reduction of total heart failure hospitalization with the ferric carboxymaltose group compared with 54% of the placebo. So 48% reduction compared with 54% of the placebo. You can see the P value is quite significant as well. So we'll go then to the secondary endpoints, which is as well was very significant. And the secondary outcomes was basically the first heart failure hospitalization or the cardiovascular death. You can see here there was significant reduction for both the secondary endpoints when the patients received FCM or ferric carboxymaltose with a p-value of 0.03, which is also significant. So both the primary and the secondary endpoints were quite obvious here. There is one point which I need really to stress on it, especially in the elderly, which is the change in the serum phosphate. You have to bear in mind, if you remember the Affirm trial, the ferric carboxymaltose in the Affirm trial caused significant hypophosphatemia, which was a critical values. And you can depict here that the serum phosphate dropped, but not significantly till the 6th week of the therapy, and then picked up again till the end of the study. So the thing that, moral of the story here, that this is severe hypophosphatemia can cause really drastic complications like rhabdomyolysis, heart failure, and even acute respiratory failure. So I think it does seem prudent to monitor the serum phosphate in such patients, especially the elderly, and manage both the iron and phosphate supplementation accordingly in a parallel way. So put this in mind when you start the medicine. You have to get a baseline phosphate. And then after the injection, maybe after a few days of the injection, you have to follow up the phosphate, maybe on an OPD basis, actually. Okay, so in all patients admitted in hospital with acute heart failure, the iron deficiency should be searched for. This is the thing you have to think about it, because if you just forget it, you will not think about it. It's very important, because many of us actually will lose the thing about correcting the iron deficiency in those patients. And we rely only on the RNA, the dapagliflozin, and the beta blockers and all that, but we never think about that. And it is assist basically the iron deficiency using a very simple blood test. I'll get to it at the end as well. So patients with iron deficiency tend to be elderly. You all know this, and they usually have more comorbidities. And you know that the inclusion criteria here in this study was basically the average age was around 71. So they were elderly patients. They usually have a longer hospital length of stay and higher readmission rates. So a very simple equation is used to calculate the transferrin saturation. So take a look at this. This is a very simple one. The transferrin saturation equals the serum iron concentration divided by the total iron binding capacity, or the TIBC. So, and then you multiply short by 100 because of the unit. So the thing that less than 20%, it should be considered abnormal, transferrin saturation. And this is, you can find a lot of online calculators to also convert the units, because sometimes it's confusing. There's, according to the country, according to your hospital system, you have to change the unit. Like, for example, here, I use the microgram per deciliter. So if you see the iron is 120, the TIBC is 300. So if you calculated both, like divided this and that, it will come up the transferrin saturation as 40%. And that's an online calculator. It's just based for the, for the sake of the unit conversion. So 40% is normal. So you can imagine the patients with, on the other hand, the patients with hemochromatosis, they will have a very high transferrin saturation. So this is the basis of the concept why we're doing the transferrin saturation. So the thing that it's very easy, it's a simple equation. You just have to do it for every single patient admitted for acute heart failure. Don't forget that. Coming to the end, I'd just like to refresh your memory regarding the FAIR heart failure, the confirmed heart failure, the EFFECT heart failure trials. They all demonstrated that the IV iron supplementation improves exercise capacity, symptoms, and quality of life in iron deficiency heart failure patients. However, none of those studies included the patients admitted with acute heart failure and received ferric carboxymaltose on discharge, as in the Affirm acute heart failure. So the million-dollar question here is, of course, is what will the results of this study mean for the guidelines? I think they probably would change the guidelines later on. We know that the IV iron therapy is only a class 2B recommendation in the 2017 American College of Cardiology guidelines for patients with NIHA class 2 and 3 with iron deficiency. And it is a class 2A recommendation in the European Society of Cardiology 2016 guidelines for also symptomatic HFrEF patients. So we will see what happens during the next years. At the end, treatment with ferric carboxymaltose was safe and well tolerated. And we have to do, we have to do is give it to the right patient. Thank you very much.
Thanks a lot, Fadi, for this actually overview of the Affirm acute heart failure. Back to Karim for the discussion, and then we'll take questions from the panel. Karim, are you there?
Thank you, Fadi. Again, brilliant presentation, and I believe we have a new piece of data that we should use in our heart failure patients. As you mentioned, we all forget to check the iron concentrations and ferritin concentration in our heart failure patients, and we should take this into consideration in managing our heart failure patients, because this can improve symptoms, and as you mentioned in the Affirm-AHF trial, can prevent or decrease heart failure rehospitalization mainly, I believe. So thank you so much, Fadi. This was a very, very elegant presentation of this very important trial.
Thank you, Karim. I appreciate it really. Thank you.
So actually, it's nice for the heart failure patients to find some candles lighting hope for them. They are lucky enough to have sacubitril valsartan in the past 5 years, and they are lucky enough to have the dapagliflozin and the empagliflozin with the positive data upon the hard endpoints, even if the patient is non-diabetic. And now the acute heart failure patients also are lucky enough to find this ferric carboxymaltose, and this will pave the way for other iron molecules also in the next several years with ongoing trials. And I think eventually we will get a guideline recommendation of treating the anemia in acute heart failure patients, and this will have a very positive outcome. So since we don't have any more discussions regarding this particular trial, I will go to the next speaker, which is Dr. Ahmed Bindari. Ahmed Bindari is a lecturer of cardiology at Banha University. He's a very eminent speaker and a very elegant scientist. Ahmed will be discussing also two updating clinical trials. Unfortunately, physically, he cannot be with us, so he was generous enough to have the recording of this discussion. I will start streaming his recording in the next 1 minute, and after the first trial, we will stop for discussion, and then we will continue with the second trial. So I will start streaming now in the next few seconds.
co-primary efficacy endpoints. The first was a composite of cardiovascular death, stroke, hospital admission for heart failure or acute coronary syndrome, and the second was days spent in the hospital. The primary safety outcome was a composite of death, stroke, or serious adverse events related to rhythm control. Actually, the trial was stopped for efficacy after a median of 5 years follow-up. The primary outcome event occurred in 249 patients in the early rhythm control arm versus 316 patients in the usual care arm. The hazard ratio was 0.79 with a confidence interval ranging from 0.66 to 0.94. The p-value was statistically significant. The absolute risk reduction was 1.1% per 100 person years of follow-up, and this translated into 3% absolute risk reduction over 5 years. Each component of this primary outcome was numerically lower in the early rhythm control. In a trial of almost, as I said, 2,800 patients, there was 27 fewer cardiovascular deaths in the early rhythm control. The average days spent in the hospital were similar in both groups. The overall primary safety outcome did not differ significantly between the two treatment arms. However, serious adverse events as shown related to rhythm control therapy occurred in 4.9% of the patients assigned to early rhythm control and 1.4% of the patients assigned to the usual care. East-AFNET trial was a clearly positive trial that had a small effect size and important benefits. However, whose hearing coverage related to rhythm control therapy occurred in 4.9% of the patients assigned to early rhythm control and 1.4% of the among patients with early atrial fibrillation and cardiovascular conditions. And now, let's speak about some comments and caveats on this paper. The first caveat is a missing data. This was a 5-year pragmatic trial of two different strategies. Some dropouts, of course, is expected. This totaled 9% in the early rhythm control arm and 6.6% in the usual care arm. One of the experts on clinical trial design said that missing data approaching 10%, I just said, can potentially invalidate an intention to treat analysis. This dropout, as I said, was not uniform between both groups, one group 6.6% and the other group 9%. To be frank, the authors did multiple statistical techniques to accommodate for this dropout, and this upheld the main findings, but we don't know the characteristics of those patients who withdraw their consents or drop out, which is the reason for a pause or a reason for a caution. Another internal validity concern is that the two components, or let's say two components of the primary endpoint, which is hospitalization due to heart failure or acute coronary syndrome, is dependent on the clinician decision. And you know that East-AFNET 4 trial was an open label trial. The investigators knew which arm is the patient assigned to. So consider that participating centers were chosen because they are experts
So before we move to the next trial, I hope you are all hearing me now. Sorry a little bit for the glitching of the voice. This is because the lecture is recorded. So maybe I will be back again to Karim. I think although the voice was a little bit far and glitchy, but I think we got the message. Karim, what do you want to say about this trial?
Thank you, Zaran, and I'd like to thank Dr. Ahmed Bindari for being with us through this recorded lecture. I believe the East-AFNET 4 trial was suggesting that the early rhythm control is more effective regarding the reduction of adverse future cardiac event as compared with rate control. I think we tried as much as we can in our patient to achieve rhythm control, and this trial confirms that this strategy might be beneficial. The point is that the method to do the rhythm control was variable in this trial. So they tried the antiarrhythmic drugs, catheter ablation, as well as cardioversion in some patients. As Ahmed mentioned, this requires a high experienced center in managing AF patients, because this center will have an access to both the drug therapy and as well as the catheter ablation therapy that is improving in last years and getting more popular in managing AF patients. So I think to conclude my understanding to this trial, we should try AF rhythm control for our patient as far as we can, especially if the atrial fibrillation is recent, less than 1 year.
Karim, I think this also goes a little bit different from what we were trained to learn, that rhythm and rate control are equal. Apparently, it's not equal, and apparently not every type or every patient with atrial fibrillation is the same like the other patients. It's not one size that fits all. Atrial fibrillation is a very wide spectrum, and the treatment is on patient-by-patient basis and needs to be tailored, because the outcomes, as we see with the more progression of science and the more better medications and the more rhythm control availabilities with less side effects than the previous drugs that have been established for several decades, actually, and choosing the particular patient will make a difference on the hard endpoints eventually. So we didn't have any discussions regarding this part of the lecture, so I will start sharing the second part now.
Trial is called Dapa-17 trial. It was published in JACC, and it compared percutaneous left atrial appendage occlusion or closure with direct acting oral anticoagulant in patients with AF. And this trial attempted to fill a crucial knowledge gap. Is left atrial appendage occlusion as good as DOACs for stroke prevention in high-risk AF patients? The background of the trial was straightforward. Of course, given the limitations of vitamin K antagonists for preventing stroke in AF patients, a novel site-specific therapeutic alternative such as mechanical left atrial appendage occlusion entered the clinical practice. But this has not been compared with the current safe and really effective new oral anticoagulants. So, if we consider the rising global burden of atrial fibrillation, plus the difficulty of taking high-risk patients with AF to either left atrial appendage occlusion or to WAP and followed them for a median of 21 months. The average age was 72 years, the chance score average was 4.7, this is a high number, and the Hasbled score was 3. About a third of patients had had an embolic event and nearly had had a history of bleeding. Those actually are very problematic patients. The researchers chose an extremely broad composite endpoint of count with stroke, or TIA, systemic embolism, clinically significant bleeding, cardiovascular death, or a significant procedure or device-related complication. Or this choice was the key flaw in this trial, as I will discuss later. But all in all, there were 47 primary outcome events in the DUWA group, where the 38 in the left atrial appendage arm, resulting in a hazard ratio of 0.84 with confidence interval ranging from 0.53 to 1.31. Because the upper bound of 1.31 was less than the non-inferiority margin of 1.47, the authors claimed non-inferiority. Each component of the composite occurred in small numbers, leading to a wide confidence interval, as I will discuss. Now, the efficacy endpoints, as we see, stroke and transient ischemic attack were similar in both groups, and the hazard ratio was 1. But look to the confidence interval. Confidence interval, however, ranged from 0.40 to 2.5. Components of the composite endpoint were not powered for comparisons, but the upper bound of 2.5 here would have far exceeded the non-inferiority margin I just mentioned of 1.47. The safety endpoint of bleeding was also similar in each group. The hazard ratio was 0.81, had a lower bound of 0.44 and upper bound of 1.52. In other words, the device could reduce bleeding by 56%, or, and sit down for this, worsen bleeding by 52%. This is a wash, no advantage. Another safety concern was that 9 patients in the device arm, about 5%, experienced a serious event, including 2 deaths directly related to the procedure. The authors concluded that among patients at high risk for stroke and increased risk of bleeding, left atrial appendage closure was non-inferior to DUWA in preventing major AF-related cardiovascular, neurological, and bleeding events. And I disagree. We have problems. But please allow me a brief diversion into non-inferiority trial design. One way to make progress in medicine is to develop superior therapies. This is good, but another way to improve patient care is to find therapies of similar efficacy that are more convenient, less invasive, or less toxic than established treatment. Okay, for instance, in selected patients, therapy can be nearly equal to surgery in relieving aortic stenosis, but have the advantage of being less invasive. A DUWA could be just as good as warfarin for stroke prevention in patients with AF, but have the added benefit of less bleeding risk and more convenience. The putative mechanism of benefit of left atrial appendage
I would like to thank Ahmed Bindari for joining us. And regarding the particular sound issue, this is because we are sharing the recorded video. I will share the original one on the YouTube channel immediately after we finish. So it will be available in a very high quality voice, no problem about that. Maybe I would like to highlight my personal point of view about trials that compare devices or procedures to medications. This is something like comparing medical therapy to stents in the famous trial, comparing Watchman device to anticoagulants. The problem is in the design of the trial. Usually you get some pitfalls, just like Ahmed Bindari highlighted, that the pitfall of adding events from both sides, like thrombotic, embolic events on one side and bleeding at the same side, with the device-related complications and including all of those in the primary endpoint, of course, is some form of, let's say, legal but still statistical bias. So maybe I would like to take some insights from Fadi if he's with us. What do you think about this particular trial, Fadi? Because usually I'm not a fan of trials that compare medical therapy to devices, unless devices is the standard of care, actually.
Thank you, Zohran. Thanks, Bindari, very much for this outstanding lecture. So the thing, I believe that actually the rhythm control will finally win in minimally symptomatic or asymptomatic AFib. So it depends about each patient. The thing that if you have patients which are quite symptomatic, then you have to think about the devices, the catheter ablations, and all that. And regardless of the stroke risk, I'm talking only about the rhythm control in the beginning. So if the patients are like asymptomatic or with very mild symptoms, I think rhythm control will finally win in those patients, and we don't have to rush for catheter ablation. And regarding the devices, there's a lot of controversy, even in the guidelines and in the literature, and even in the old studies before, regarding the devices. Because even the devices in some of the studies um, uh, uh, caused actually some complications eventually. And some of the patients who were not on the warfarin and on the other arm of left atrial appendage device closures, they had eventually some events, even they had the devices. So apparently it was it was inferior. It was not superior to the VKA or the NOACs and or the anticoagulants at the end in some of the studies. So I believe that we have to somehow like correlate the patient criteria according to the decision we do. Unfortunately, in my working, I don't have an EP center. I mean, I don't have the EP facility, but usually when there are patients and we start the rhythm control and everything, and we do the TE study before assuming or taking any decisions before cardioversion. Later on, I discuss with my colleagues, like Dr. Hani Sabur. You've seen him. Actually he was intervening in our in my lecture in a very nice way with the questions. He's working in a very high center in Cleveland Clinic in Abu Dhabi. So usually we have some kind of like a team meetings, so we can really discuss our patients. What's the best for those patients? Is it a device therapy, or is it catheter ablation, or is it just rhythm control or rate control? So it depends about the age, it depends about the patient symptoms. In many instances, just like Ahmed Sheikh also mentioned in the Zoom chat, that there's a lot of controversies even in the Affirm trial, because the guidelines somehow is a bit of like a controversy for the current practice. So I believe each patient is different from another, and we cannot just rely the guidelines to every single patient we see. So, so the thing that another thing is also the patient compliance, because and somehow if the patient is really low risk and compliant to the medications, especially the anticoagulants, so I don't think we should rush to the device. And the device usually has its own implications and also recommendations, like patients who cannot really tolerate the anticoagulants for a long time, or they have such kind of like high risk of bleeding. if they have a long-term anticoagulant. So it's a case-to-case based, and I'm sure that it's very difficult to tell which patients should get this and should get that, but it should be discussed according to the patient in a hard team approach as well.
Yes. For me, I'm not so enthusiastic about the left atrial appendage closure for every single patient except in selected patients. And this goes for me in the same line with the IVC filter for DVT patients, except also in selected patients. I felt that sometimes during the past several years, there have been a little bit of abuse in the form of using excessively of particularly those two devices, the left atrial appendage closure device and the IVC filter. Maybe I would like to take a short comment from Dr. Haitham Suleiman, if he's with us.
Thank you, dear Zahran. Sure, the restoration of sinus rhythm is more physiological, and this is the best option for the patient. But as Dr. Fadi said, we must weigh the risk and benefits of for each patient, especially the recurrence, because regarding the left atrium and the left atrial volume and the chance of recurrence, and regarding the AF nature itself, that it's a very recurrent disease. So I think the initial evaluation should include the chances of recurrence, whether we are trying medical treatments or interventional treatment. I am agreeing with you, Zahran, that I'm not fond of the Watchman device or the trials of left atrial appendage closure. And I don't think these are an effective methods. So I think that we should include the chance of recurrence as a cornerstone when evaluating any patient before adopting rhythm control. It's very, very important. It's more physiological, but unfortunately, it's not a very lasting or dependable choice for more than half of our AF patients.
Yes, I do agree with you, Haytham, and I do agree with what Fadi also said and Ahmed Sheikh, that actually it's tailored, and I think that patient by patient basis and co-management and let's say expert opinions and referral to specialized center is the standard of care that we should all follow for those patients. So I think we are coming to the end of this session. I'm very happy actually, and I'm very glad and pleasured and honored to having hosted tonight Dr. Fadi Girgis, the president of the International Young Academy of Cardiology, EAC, and the consultant of cardiology at United Arab Emirates. I'm very glad also for Dr. Ahmed Binderi to join us, and I will upload his recorded lecture in a very high quality in the next few minutes on the channel also, so it will be available because Ahmed also has a very good point of criticizing the clinical trials from the statistical point of view because he's an expert in this particular field. I would like to thank all the attendees with us tonight, special guests from invited by Dr. Fadi. You made us proud by your discussions and your valuable attendance, and we hope to have you all on the CEC scientific board, hopefully. And I would like to thank Dr. Karim Mahmoud and Dr. Haitham Suleiman for moderating this scientific night. And for the next 2 or 3 Thursdays remaining in December, we will be going through the updates of the clinical trials in 2020. And by the beginning of January, we'll have a very big surprise for all our viewers and members. So see you next week.